Yeah.
Yes, we're good to go.
Very good. So good morning, everyone. My name's Emily Kearns, and I'm the coordinator for Dementia-Friendly Baltimore County, and we are supported by the Department of Aging, Baltimore County. I work out of the Caregivers Program here, and this is such a wonderful event, a really unusual offering. So we are very excited to have you and our esteemed panelists with us today. So we will start right away with an overview of today's agenda. So we will hear from the three panelists, Albert Garcia-Romeu, Michael Lepore, and Melinda Webster, in that order. They will present for about half an hour. And so we're asking you to save your questions for the end of each of their presentations. We will have a full 2 hours, so that's wonderful. We'll have plenty of time. And at the end, we will have announcements about other upcoming events operated or hosted by Dementia Friendly Baltimore County and also our Caregivers Program. So if you have any difficulties, you can put in the chat your technical issues, and we are wonderfully appreciative of the support we have from our communications team. We have with us today Deja Yop, Diane O'Brien, and Ethel Rasmussen. We also have with us today the manager of Caregivers Program, Kathleen Koenig-Stoffel, and she's very supportive, as is all of the staff and management here at the Department of Aging of Baltimore County. So let's just jump right in. The first panelist is Dr. Albert Garcia Romu, Assistant Professor of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. He's also a founding member, Johns Hopkins Center for Psychedelic and Consciousness Research, and the International Society for Research and Psychedelics. I should also remind everyone that this meeting is being recorded and that the PowerPoints will be available after this session. Thank you. Dr. Garcia-Romo, why don't you take it away?
Great, thank you. And I'm just going to go ahead and share my screen here. And so just give me a moment to get that going. And I will get the slides up. And can you see that all right?
Yes, we can.
Great. All righty. So yeah, my name is Albert Garcia-Romeu. I'm a researcher at the Johns Hopkins School of Medicine. And we have a center here called the Center for Psychedelic and Consciousness Research, where we're studying new types of treatments, including psychedelic drugs as therapeutics. One area that's been of interest to us lately has been specifically using psychedelics as therapeutics in older adults, particularly in dementia, but we think there's a lot of possible directions to take this type of work. So we're really excited to explore that and to talk to you about that today. And just to begin and give a little bit of context, I'll be talking about drugs that we call classic psychedelics. These drugs are primarily serotonin 2A receptor agonist drugs. And what that means is that there's about 14 different types of serotonin receptors in the brain. And serotonin is one of the major neurotransmitter systems that we know regulates things like mood, sleep, appetite, and sex. And so this specific type of receptor, the serotonin 2A receptor, is known to be a target of psychedelic drugs. And you can see right here on the right a little heat map where there are more of these serotonin 2A uh, uh, receptors in the cortex, and they happen to be very important areas all over the cortex. And one of the reasons that we know that these psychedelics are agonists at these serotonin receptors is because of the structure of the drugs themselves. And so you can see psilocin, this is what psilocybin is broken down to in the body. And I'll talk more about psilocybin in a moment. But these are all these classic psychedelics: mescaline, which is found in cacti, psilocin, which is found in mushrooms, dimethyltryptamine, which is found in a number of different plants and animals, and LSD, which is a semi-synthetic drug that was synthesized back in the 1930s. These are all the classic psychedelics, and they bear a striking similarity to serotonin, that neurotransmitter system. And so as a result, we know that there are important activities of these classic psychedelics in the brain at the serotonin receptors. And psilocybin is particularly one of these drugs that's been studied a lot in the last 20 or so years. I've been working on research with psilocybin at Johns Hopkins for 11 years now. And psilocybin is fascinating because it's a psychoactive agent that's found in over 200 species of mushrooms. And these mushrooms grow all over the planet. And of course, they predate mankind. But as a result, humans have a very long history of using these types of psychedelic containing mushrooms, these psilocybin mushrooms. And you can see that in artifacts that date back thousands of years, including stones like these from Guatemala, showing that they're often thought of as sacred or important part of their ritual and spiritual life in indigenous cultures. So this is a really long-standing area in many ways because of indigenous spiritual and traditional use. Actually, who you see here is Maria Sabina, who is an indigenous healer in northern Mexico, who actually was the first to introduce Western scientists to the psilocybin mushrooms in 1955. And that eventually led to the synthesis of psilocybin from the mushrooms, or actually extraction first, by Dr. Albert Hofmann. He's a Swiss chemist. He was also the discoverer of LSD, but he was working at Sandoz Labs in the 1930s and 40s, trying to develop new medicines, and ended up developing LSD, and was later the first person to extract and then synthesize psilocybin from these mushrooms. So this is scientifically an area that's relatively young because we didn't even discover psilocybin until the mid 1950s, and research really did kick off at that period pretty quickly. However, as we're well aware, there was also a lot of adoption of these psychedelics in that counterculture during the 1960s, and that led to a substantial backlash in terms of regulations and basically these psychedelics and cannabis being outlawed. But I think it's really important to understand that these types of drugs have a long history of spiritual and traditional use in indigenous cultures, much of which was not really seen as problematic in any substantial way. Of course, there's also a long history of recreational use, and that included use in the 1960s among the counterculture that also ended up leading to much of that backlash, which made it really hard to do work in this therapeutic and medical area since the 1970s, roughly. So really, it's important to understand that all these perspectives, I think, are valid and valuable. They may have something for us to understand, but where we're coming in to do this work nowadays is really from this therapeutic medical approach, at least with our group at Johns Hopkins. And so it's important to keep that in mind, that we're not talking about spiritual use per se, we're not talking about recreational use, but really studying these drugs as possible medicines. And what's been fascinating from a cultural standpoint is that since the discovery of psilocybin in 1958, there was an increase in research publications about psilocybin through about 1970, when these psychedelics were outlawed during the Nixon administration. Um, that eventually declined pretty rapidly, and you can see here in the mid 80s and 90s, there's almost no research being published around these types of compounds, and particularly psilocybin. However, that starts to take off again in the 2000s. And so over the last 20 years or so, we've seen what a lot of people have talked about as a psychedelic renaissance, which includes new research on the drugs and their effects, in particular on their potential benefits. And as a result, you see also quite a lot of popular media. This is from Time magazine, but there have been, since the mid 2010s, a lot of research interest that has also translated to popular media coverage like this, where folks are asking, do LSD and magic mushrooms have a place in medicine? And so a lot of that work has really been accelerated here at Hopkins. So Hopkins has been a hotbed of research with psilocybin in particular since about the early 2000s. And really, Roland Griffiths and colleagues, Matthew Johnson, Bill Richards, these guys really got the ball rolling again around 2000 on some new research with psychedelics after several decades of minimal research. And what they started was really a program of research with psilocybin to understand the drug effects, including, how do those drug effects healthy volunteers? Eventually, how does that impact people's personality? And as that work developed more, we started moving much more in a clinical direction, specifically looking at using psilocybin as a treatment for various types of health conditions. And so that includes work that we've published on psilocybin assisted therapy for smoking cessation. This is specifically for people who want to quit smoking cigarettes. Um, Psilocybin in palliative care settings, specifically for cancer patients with terminal diagnoses who are also struggling with anxiety and depression. Looking at the effects of psilocybin in spirituality and meditation, but also as a treatment for major depression. And more recently, we've expanded our clinical portfolio to include studies on things like psilocybin in patients with Alzheimer's disease, anorexia nervosa, and a number of other studies that are in progress or in planning. And so a lot of that has been philanthropically funded. We started doing this work about 20 years ago, but in 2019, we were able to secure a large gift from philanthropic donors to establish this psychedelic research center, which has really given us the opportunity to expand in all these new directions. Now, Hopkins has not been the only people doing research in this area. And so as a result, we've seen over the last couple of decades multiple studies that are showing that one or two doses of psilocybin can have rapid and enduring antidepressant effects that are as good or better than standard antidepressant treatments that are currently available. We've also seen a number of studies showing that in patients with cancer and related anxiety, that one or two doses of psilocybin can lead to persisting reductions in their anxiety and depression and increases in quality of life in the cancer patients. And I think it's important to differentiate here. We're not specifically targeting the cancer itself, but really helping to enhance people's mindset because often they're feeling so demoralized, hopeless, and depressed because of their illness that they really are struggling to get the most out of the time that they have. And there's also been lots of interesting studies using psychedelics to treat various types of substance use issues, including tobacco and alcohol use. Um, but I won't talk too much about that today. But all of this promise that we've seen so far really kind of poses a question: what's next? Where else can we take this, and where can we study it? And that led directly to the study that I'm going to talk to you about today, which is specifically looking at psilocybin in patients with mild cognitive impairment or early stage Alzheimer's disease. And before I get there, I just want to set the stage a little bit by giving you a background of some of the currently available data regarding psilocybin treatment. So this was from the study that we published in 2016 in cancer patients who had anxiety and depression related to their illness. And what they found was after one high dose of psilocybin, 60% of the participants had a remission of their depressive symptoms as compared to less than 20% of a placebo low dose of psilocybin, showing that there was a very significant difference in terms of the therapeutic effects of a single high dose of psilocybin. And this was something that was sustained up to 6 months later, when about 70% of these participants were still showing reductions in their depressed mood from the baseline before they started the treatment. This is also true in terms of reductions of anxiety. And so really what you're seeing here is that 80% of the people in this study showed a clinically significant improvement that lasted up to 6 months after one high dose of the treatment. And that also led to things like increased quality of life. Other labs have also been working in this area using psilocybin, for instance, in the treatment of major depression. This was a study that was published in the New England Journal of Medicine in 2021 by a group of researchers from Imperial College London. And they did a really interesting study design here. What they did was they gave people with major depression either two doses of psilocybin here and here, or daily escitalopram, which is also known as Lexapro, as a standard approved SSRI antidepressant medicine. And what they found was that the people who had one and then the second dose of psilocybin um, are, on average, doing better in terms of reductions in depressive symptoms than people who are taking a daily dose of a currently approved antidepressant medication. So these people are taking the same medicine every day for 42 days, and this is a reduction that you see in their depressive symptoms. These people had 2 days of dosing with psilocybin, and what you have here is a reduction that lasts up to 6 weeks after the first dosing session. So that's pretty impressive. And we're continuing to see that, and it's again not just at Johns Hopkins, but these are in research laboratories around the world. Specifically, this is from our colleagues in Zurich, Switzerland, where they did a really nice placebo-controlled study where people either got a course of talk therapy with a placebo dosing day, where they basically laid on a couch all day and nothing happened. And you can see they had some reductions in their depressive symptoms with the talk therapy. But then there was a group that got talk therapy and one high dose of psilocybin here. And again, you're seeing a significantly greater reduction in their symptoms of depression. And this is the cutoff here for where people meet depressive criteria. And you can see that they're basically getting to the point where they may no longer meet criteria for depression after one single dose with some talk therapy. And that's not the case in these placebo conditions. So again, the data are pretty compelling, and they're continuing to accumulate, which has really been quite encouraging for us. Some other work that our group has published over the last couple of years specifically looked at the effects of one high dose of psilocybin on emotion and brain function. And what my colleagues here have found is that when giving a person just one high dose of psilocybin, you're seeing substantial changes in brain activity that lasts 1 week and up to 1 month after the drug experience. And so there's something going on here that's related to changes in emotional processing, including parts of the brain like the amygdala, and the way that our brain is just processing information in general. And that's represented, for instance, in areas like the anterior cingulate cortex that, again, are showing different patterns of activity up to a month after a single exposure to the drug. So that's really led us to where we're at now, which is a small pilot study examining the impact of psilocybin on depressed mood in people with early stage Alzheimer's. So as you're probably aware, we have more than 55 million people worldwide living with dementia, right? Currently, and that's going to be estimated at 78 million people in 2030, and over 130 million people by 2050. So this is just an exponential increase in terms of the numbers of people struggling with these Alzheimer's and dementia related conditions. Over the last few decades, we've had over 240 different drugs studied as potential therapies in Alzheimer's disease specifically, um, the vast majority of which have not been approved for any sort of therapeutic indication, meaning that these were failed drug candidates. They didn't really show safety or effectiveness. We also know that people with mild cognitive impairment and Alzheimer's disease have a very high prevalence of comorbid neuropsychiatric symptoms. So what that means is about half of these folks are going to have some sort of depressed mood, apathy, anxiety, and these are uh, conditions that significantly impact quality of life negatively for people, and not just for them, but also for their caregivers and family members who are close to them. And for instance, just looking at one specific figure here that I thought was very impressive and frightening is that in the first 3 months after getting a diagnosis of dementia, you see the risk of suicide increase to more than double, as opposed to people who have not gotten that diagnosis. And so it really just speaks to the level of psychological distress that can come along with these types of conditions. Just doing a little bit of backtracking here. There's been a lot of research in animals and cellular molecular models with these drugs over the years as well. And what people have found by and large is that psychedelics like psilocybin seem to induce some sort of neuroplasticity, including neurogenesis potentially, or growth of new cells in the brain, and accelerated learning. We've seen lots of different types of learning, from associative learning, avoidance learning, and working memory, all being enhanced by even a single administration of these serotonin 2A agonist psychedelics. And so these also suggest a potential area for benefit, specifically in helping cognitive function in folks who are struggling with memory problems. And some of this work has just been really fascinating to see develop. But really, the take home here is that these are our neurons or brain cells that we use to process information in our brains. And when we have degeneration, often we're having degeneration of the cells, but also of the synapses, which are the connections between the cells. And we've seen in multiple studies now that just one exposure to a psychedelic like drug can create the growth of these new connections in between the brain cells. And this has been shown to happen in mice, for instance, to last over a month after a single exposure to psilocybin, where you can see this increased spine density that's ongoing up to a month later. And that's also associated with things like enhanced excitatory neurotransmission in the brain, and also enhanced learning, accelerated learning processes in these animals. And so, again, this is really promising and exciting area to look at. And so that has encouraged us to do this pilot study that we're currently enrolling folks for, but it's a study in 20 treatment-seeking people with depressed mood and a diagnosis of either mild cognitive impairment or early stage Alzheimer's disease. The study involves an 8-week treatment where people are in meetings, counseling meetings once a week. And in 2 of those weeks, we also have psilocybin dosing sessions using a 15 milligram and a 25 milligram dose. And then what we're doing is following up with those individuals 1 month, 3 months, and 6 months after their last psilocybin session. Our primary aims are to test if depression is improving their depression and quality of life. But we're also looking at measures of anxiety, memory, and caregiver quality of life as well to see if it's having any impact there. This is what the study looks like. From week 1 through week 8, we're having weekly counseling visits. We're having a few of these visits be on site. Many of them are conducted virtually, as we're doing here today, using virtual telehealth counseling. And you can see we're doing a number of measures like the Cornell scale for depression and dementia, the Beck depression inventory, and so on. And we're taking them before and after the drug dosing. In the psychedelic therapy that we practice, we always do an intensive screening beforehand. We're looking for any issues like cardiovascular problems or history of certain types of psychiatric conditions like schizophrenia or bipolar mood, which may cause problems for people who receive high dose psilocybin. But then once they're through the screening process and we've determined safety for this person, then we're going to go ahead and do a study treatment that involves that counseling for 8 weeks. That's usually involving 2 facilitators who work with the individual from the beginning through the dosing sessions and in aftercare, which lasts approximately 2.5 months. During the preparation, we're doing supportive counseling to understand the person's life history, important life events, and really form some treatment goals to understand their symptoms and figure out what it is that they would like to get out of this experience. We do the 2 drug sessions on site at our laboratory at the Bayview Medical Campus in East Baltimore. Those dosing sessions last about 8 hours and are conducted in a living room-like environment. The 2 facilitators are there throughout the dosing session, and we just ask participants to lay down on a couch. They'll typically have their eyes covered, be listening to music through headphones, and we tell them to focus their attention inward. And so this is what a session might look like. And we have a number of these going on at any given point at our laboratory. And so far, where we're at is we've enrolled 8 individuals. They've all been white adults with cognitive impairment or early stage Alzheimer's disease. 5 were women, 3 were men, and the average age was 70 years. So far, we've done some preliminary data analysis on the Cornell scale for depression and dementia. which is a clinical interview with the patient and their caregiver or family member to assess mood-related signs like anxiety and sadness, behavioral disturbances, sleep problems, and other ideational or disturbances. And what we found so far in the first 8 patients is that there's a significant reduction in depressive symptom scores, lasting all the way out to 1 month after the high dose. This is still preliminary. And what's interesting is that we're also seeing data that are not 100% consistent. So on one of our measures of depression, we see a significant reduction. On the other, we don't really see much of a change at all. The big difference between these two is that this is asking not just the patient themselves, but also asking usually their spouse or a close family member who's able to observe them. And I think that that's why we're seeing more of these reductions because these folks are able to give us a little bit more perspective. Whereas, when we're asking just the patient themselves, they may not be seeing the change over time, potentially due to some of their memory impairment issues. So right now, though, I would say these, are preliminary data. We're hoping to enroll 12 more people, but it's really interesting to see that, at least from the caregiver standpoint, they are reporting spouses, children, family members, that these individuals seem to be getting some antidepressant effects that are lasting several weeks or longer after 1 or 2 doses of the drug. And we're still enrolling 12 more individuals for the study. To participate, people would just need to have depressed mood and either early stage Alzheimer's disease or mild cognitive impairment diagnosis from their doctor. Um, Typically, we have a family member or close friend who's also part of the process. We've, as I said, enrolled 8 people, and all 8 have safely had 2 drug sessions, so we haven't had any problems there at all. And again, we'll be enrolling 12 more people. And so for more information, you can feel free to email me here or call me at this number. And we also have a website at our lab, which is hopkinspsychedelic.org. And that's got all the relevant information for people who would like to sign up or get some more information. So I'll just leave it there for a moment in case anybody wants to jot that down, and then I will stop my screen share and allow the next speaker to come on here. Thanks very much.
Thank you very much. I think we're going to pause and just see if there are any questions right now. And then again, at the end, we'll have questions for all 3. But just since the presentation is fresh, does anyone want to unmute and ask any questions about the study? We have a minute or 2 for that. I think it's really exciting because the quality of life after diagnosis is so important. And as you said, we're seeing depression and suicidal, um, you know, tendencies because of lack of resources, also lack of hope.
Yeah.
And what I find really important is the caregiver, the care partner participation in this. And their awareness. And I would imagine it would be hopeful and improve their quality of life as well. And it sounds like that's what you're finding. Okay, Jackie says we cannot unmute. Let's see, I'll read the questions that are coming in. Let's see if I can. Is there an age limit? Is a question from Leslie.
Great question. Yes, there is a upper age limit of 85. So people who are 86 or older, unfortunately, would not be eligible to join the study at this point.
Thank you. And Jackie Schroeder asks, whoops, sorry, what is a micro dose? And she also asks, what is a high dose?
Yeah, great questions as well. High doses are typically in the range of 20 to 30 milligrams of psilocybin. Microdoses are usually closer to 1, 2 milligrams of psilocybin, very low doses. There's been a lot of media hype around microdosing. There's stories online, if you go look, about how microdosing on your first date can make it better. How microdosing can be great for all sorts of things. I'll just tell you as a scientist, the microdosing literature has not shown any clear sign of benefit for anyone. Some people feel a little better, some people feel worse and more anxious. It hasn't been well studied clinically, and any particular population. Um, but what we're using are high dose treatments because those have been the ones that have typically shown the benefits that I was discussing earlier, things like antidepressant effects and so on.
Thank you very much. Another question from Mary Wantrip. Have any studies been done on dependency development of the treatment?
Great question as well. So that is really interesting thing about these drugs is that they create what they call tachyphylaxis, meaning the drug creates rapid tolerance. And so if you take the drug every day, eventually your body will stop responding to the drug. And as a result, it also does not create a withdrawal syndrome, which is one of the major features of addictive substances like alcohol, opioids, cocaine, meaning that once you stop taking it, you feel pretty bad and so you want to take more to continue to feel better. So neither the withdrawal nor the tolerance features of these drugs are similar to addictive drugs. And when you give animals access to these types of drugs, they don't usually give themselves the drug over and over again, which they would do with something like alcohol or cocaine, for instance. And so these drugs are not really seen to be habit forming or have a high abuse potential or potential for addiction, thankfully. Usually in these types of studies, we'll administer it once or a few times, and typically we don't have problems with folks going out there and seeking it again on their own.
Great. I think we have time for one more question. Let's see. Jackie writes, why are these not safe for people with cardiovascular issues?
So the main issue is that we know that these psychedelics also cause excitation of the cardiovascular system, specifically increased blood pressure, increased heart rate. So, people with things like a history of stroke, a history of heart attack recently, hypertension that's uncontrolled. Those would be folks that we would screen out for safety purposes that we just wouldn't want to overexcite their cardiovascular system.
Great. So we have several more questions. I think what we want to do is to hold them till the very end, but we have at least 5 more. So I hope we have time for those. And there may be questions that also do a crosswalk between some of the other presentations too. So thank you so much. I hope, are you able to stay for
Yeah,
the
I'll be
entire?
here. I'll be here till 1, no problem.
Okay, lovely. Thank
Yeah.
you. All right. So let me introduce our next presenter, Dr. Michael Lepore. I hope I'm pronouncing all of your names properly. Uh, Dr. Lepore is a professor at the Department of Organizational Systems and Adult Health. He's the co-director at the Center for Health Equity and Outcomes Research, the University of Maryland School of Nursing. Also a professor at the Department of Medicine, the University of Maryland School of Medicine, and associate director for the Community and Collaboration Core, the University of Maryland Baltimore's Institute for Clinical Translational Research. He is as well the associate editor for the Gerontological Society of America's policy journal called Public Policy and Aging Report. So it's our delight to welcome Dr. Lepore.
Thank you very much, Emily, and thanks to Dementia-Friendly Baltimore County for bringing us together for this innovative event. I'm Michael Lepore, and thank you for the introduction. As a just brief background, I came to this work initially. I was a nurse aide in a dementia care unit, and it was that experience that led me to pursue my Ph.D., which was actually in sociology. And the focus of my work is on non-pharmacological care for people living with dementia. And I will share a bit about that and this current pragmatic trial of a treatment called cognitive stimulation therapy, and specifically a virtual delivery of that therapy. So I came to this focus on this virtual cognitive stimulation therapy by listening to people living with dementia and their care partners in a sort of series of engagement that launched with a workshop that was funded by the Patient-Centered Outcomes Research Institute, which is briefly called PCORI, P-C-O-R-I. And PCORI funded this workshop that included a Dementia Peer Coalition, which was a group of people living with dementia who were interested in being engaged in research and or advocacy policy advocacy especially, and several of the members of that coalition participated in this workshop, and those included people living with dementia and their care partners. And through this workshop, we went through this process of identifying issues that are priority issues for this target population of people with dementia and their care partners, collectively forming research questions that address those priority areas, choosing solutions that would address those priorities, and then sort of designing a study, prototyping a study. And the priority area that really stood out in one of the groups, and these were all sort of, a large group came together, but then we worked in small groups. And one of those small groups that I had the chance to work with really focused on the importance of social activity and the value of people living with dementia continuing to engage in social activity and wanting to understand the impacts of that. And so in seeking to understand how to do research on that, I found a intervention with the assistance of an occupational therapist who I worked with, identified this evidence-based therapy called cognitive stimulation therapy. And this is a group treatment for people living with dementia. However, this was all in 2020, so you could imagine there were going to be some sort of challenges arising for an in-person group therapy. That's what led to the virtual adaptation. But just to give a little bit of background, before leading up to the past couple of years, CST, as I might refer to it, or cognitive stimulation therapy, was originally developed back in 2000 at University College London. It's as a group treatment for people living with dementia. It's usually up to about 8 people, say 5 to 8 people in a group. That group treatment, CST, it involves 14 sessions is the basic, could be more, but roughly 14 45-minute sessions that each has a specific theme, and they typically run twice weekly, so it's about 7 weeks. And those, and I'll walk through a little bit more details about what each of those sessions looks like. But what research has shown, this has been around since 2000, and no barriers to doing research or providing this service. Research has shown, international research has shown improvements in cognition and quality of life and mood, communication, and in social engagement of people living with dementia who participate in CST. It's actually been recommended standardly by the UK government. Their National Institutes of Care Excellence recommends all people who are diagnosed with dementia to be referred for cognitive stimulation therapy, and it's the primary psychosocial intervention in UK memory clinics. It's really nationwide there. And beyond UK, it's practiced in at least 35 countries from my last look. There is this international CST center that commonly provides updates. My last look, there's active CST in 35 countries, but it's not too widespread here in the US yet. There are it's actually 3 manuals now. This is just a quick image of what that manuals for the facilitators or group leaders look like. So to facilitate or lead cognitive stimulation therapy, there is a training. That training is now available in the US. At least it's available in St. Louis, where there is a geriatric workforce enhancement program that provides the training. And several of the occupational therapists who I've worked with have been through this training and now deliver it. It does not require an occupational therapy degree. It just happens to be that's who I've worked with. And these manuals and the delivery is available in multiple languages, which I really did want to get through to highlighting. I've listed several of those languages here, but I expect by now also this keeps expanding, and so it might be available beyond these languages as well. I have a colleague that you will learn more about in a little while, and their group is delivering CST in Spanish as well, and I see Spanish is not listed here. So I mentioned each of the sessions has a theme. There's 14 sessions, and these are the basic themes of each session. I won't go through these in detail, just wanted to give you a quick sense for what the topics were, sort of the main topics of each of these sessions. They'll cover things, like food, like being creative, and like word games. And I would say the topics might get a little bit more complex, starting from 1 going through 14. But although the theme is different for each session, which keeps it fresh, the structure of the session is the same. All of those 14 sessions follow the same format, which really supports the participants to gain mastery and to succeed in engaging in these sessions. Early on, the group establishes, in the first session, the group itself gives itself a name and gives itself a theme song. And that's how each of the future sessions kicks off. There's then a sort of orientation discussion around the sort of the day, the weather, the place where the individuals are located, and then a current affairs discussion. That current affairs discussion is commonly led by like a newspaper article or spurred by a newspaper article or something recently in the news. So again, it's keeping it fresh and current for each session. There's sort of a main activity, which is discussing that theme of the week, and then a closeout. So again, this all happens in about 45 minutes. And ends with that theme song again. This is all intended to be a really positive experience for the participants. This is what each session looks like. And each of those sessions, although they have distinct themes and then this similar structure, they all have common goals. So really the goals of these sessions that the facilitators or facilitator has in mind is to increase attention and concentration, for the participants to exercise their word-finding skills. It increases social engagement, as this is a group treatment with, say, 5 to 8 people participating. Builds confidence in discussing thoughts. A common thing that I've heard in working with people with dementia is a sort of isolation and a lack of comfort in having conversations because of word-finding skills are lost. And so this is sort of practice where people build confidence in discussing their thoughts. And in some qualitative work I've done with participants, this really has stood out where the participants say now they're more comfortable having had these conversations in the group. They're more comfortable having conversations with friends and family members outside of the group. Elevating mood, making it a positive experience is important. Promoting social awareness, new ideas and associations, and learning new things. Really, I think getting back to that sort of constant learning and neuroplasticity that is still possible at this stage. And the literature does indicate quite good outcomes. And so I just pulled this very recent systematic review and meta-analysis of randomized control studies, and it indicated that CST effectively improves cognitive function and alleviates depression levels among people with mild to moderate dementia, and that is exactly who this therapy is designed for, people with mild to moderate dementia who can continue to participate in group conversation over a series of weeks. So virtual cognitive stimulation came to be around 2020 when gathering a group of people together was no longer viable. So cognitive stimulation and COVID-19 didn't really work together. And this was about the time when I first learned about cognitive stimulation therapy and was seeking a evidence-based treatment, something that the literature and especially randomized controlled trials had shown were beneficial for people living with dementia. And that included that social engagement that people living with dementia had prioritized. So cognitive stimulation therapy provided that social engagement, but it couldn't deliver a group therapy since 2020 in person. So we wanted to try this virtually because virtual cognitive stimulation therapy, it meets the need for people with dementia to maintain access to this evidence-based treatment when gathering in person is non-viable. So this has been delivered, in my experience, on Zoom quite successfully for a couple of years now. And so virtual CST, it really sprouted up not only in the US, but in several countries during COVID, including in New Zealand. And Gary Chiang and Kathy Peary, who are cited here, I had an early call with them in 2020 to learn lessons from them. They were very generous in sharing lessons learned about shifting a CST group that they already had underway onto a virtual platform. And this was an urgent response, to provide continuity of care and social connectedness during COVID-19. And one of the, challenges that may be obvious, but, in real life, the group had to deal with was just access to an online platform, access to the internet was the only real barrier that they faced in making this shift. So it's a really important barrier, and it could be a game-breaking barrier for some people to be able to participate. But for those who have access to the internet, this was a feasible shift to make. So here in the US, this was actually in Connecticut, we first had a pilot, just a real small, we wanted to start as small as we could. So it was in 2020, from November of 2020 to January of 2021. So again, this is that roughly 7-week cycle. There's 14 sessions that happen about twice a week, but because this went over the holidays, I think there were probably only one session on the weeks of the holidays. And as a pilot, we were extremely pleased with our findings. And this was, for one thing, we took attendance at each session. So we had only 5 participants because we wanted to keep it as small as possible. And all 5 participants attended every single session, except the one participant missed the very last session because they had other commitments. And again, as you can see, this is right around the holidays. We're very pleased with the turnout. People must have been enjoying themselves and attended. After every session, we asked participants about their experiences via email. Because we were doing this on Zoom, we were already in email communication with the participants. They were already clicking on the link to join the meeting, so we knew email communications would work, and they worked. We sent just a really brief 2 to 3 question inquiry about their experiences after every session. They provided feedback. We analyzed those data. It was 14 sessions, 5 people giving feedback. So we had a nice small set of qualitative data, but we reviewed those data. We identified some preliminary themes. We shared those themes with the participants themselves with some quotes that evoked those themes. And the participants themselves verified all of the themes that you see listed here, and only 4. One was that it was an enjoyable experience despite their dementia. So there were many specifics that the participants could not remember, but they did remember feeling good and having a good time. They felt more confident. And as I shared a little earlier, there was this experience of feeling more comfortable having conversations with their friends and family outside, in the real world, outside of this therapy. They liked the agenda. The participants liked that everyone could participate. They found it inclusive and engaging for all of the participants. And then, as I mentioned, every session had this current affairs discussion. That was really appreciated. And the participants repeatedly mentioned more controversial topics as being really enjoyable. Things like birth control, gay marriage, gun rights. These were the topics they really liked discussing, at least in this sample of 5 people in Connecticut. So we were, of course, delighted to see some of the advantages of virtual cognitive stimulation therapy, this adaptation. It's feasible and it's acceptable. We had 99% attendance, and it's potentially an acceptable alternative to face-to-face, and it certainly increases accessibility. And that's actually the difference that I wanted to highlight and really did highlight here. because our concern of shifting to this virtual platform was actually losing accessibility, that fewer people would have access. But over time, the literature and this, literature from the actual originator of the intervention is Amy Spector, the anchor author cited here, that the virtual platform is increasing access for those who can't access face-to-face groups. That might be due to COVID restrictions, but also transportation and mobility restrictions that are so common. And here in the US, we're increasingly thinking about reaching individuals in rural areas or hard to reach areas who don't have a group, an in-person group to join. So in this current trial, so I'm currently conducting a trial where physicians are referring patients living with dementia for virtual cognitive stimulation therapy. Knowing that this treatment is now increasingly available in the US through some providers, including that geriatric workforce enhancement program that's providing training in St. Louis for facilitators. In order for patients, people living with dementia to learn about this therapy, getting a referral from the physician was identified as a very trustworthy mechanism, and maybe the most trustworthy mechanism to get a referral for a therapy. And there is a National Institute on Aging funding mechanism, this IMPACT Collaboratory, which is a center that is focused on pragmatic trials. And what we've designed here is this pragmatic trial where the pragmatism is really baked into that we are not collecting primary data. We are not conducting interviews with any of the individuals with dementia. We are partnering with a primary care clinic and that primary care doc and the neurology clinic and the neurologist there. And we are asking them to review their patient populations, to identify eligible participants. That's the protocol that we're providing them. And then from the identified participants, they'll be referring some for VCST, some being the intervention group, not the control group. And then they, the physicians, are providing us at the University of Maryland School of Nursing, they're providing us data about those patients, specifically their cognitive performance scores that they'll provide us from before they refer them and then after they refer them. And then we are not actually analyzing those data ourselves to keep out of it and to keep it as clean as possible. We're actually just de-identifying all of the data and sending it off to Brown to conduct the analysis. And so our hypotheses I want to share from this study where we have physicians providing referral, our trial hypotheses is that first, I would say really not too aggressive top hypothesis, but an important one is that cognitive decline, specifically clinically meaningful cognitive decline, which we're categorizing as a 2-point change in the cognitive performance scale, but this clinically meaningful cognitive decline will be less common in the intervention group than the control group. And then on the flip side, second hypothesis, that clinically meaningful cognitive improvement will be more common in the intervention group than the control group. So we're a bit more confident in that first hypothesis. That's why it's the first. The second one is a bit more of a stretch. And then the third one, these are sort of secondary. And we pretty have high confidence in these, but we think from past experience that this virtual cognitive stimulation therapy will be favorably received based on the acceptance of the referrals from the physicians, and then the participants, their actual attendance. You know, we've seen 99% in the past. I'm pretty confident we will never see results that high again unless everyone has lockdown orders and can't leave the house. That's what we learned in late 2020. We had such good turnout, but that was an anomaly. You know, people had nothing else to do, really couldn't go anywhere else. So participating in our online group therapy was highly attractive then. I do not expect we'll see 99% attendance again. And then participant attrition, if people are dropping out during that 14-session phase, that would be a negative sign, but we're definitely going to be tracking that as well. I want to share just briefly a bit about our inclusion and exclusion criteria for who is in this trial. So, to be included, it's people with mild cognitive impairment or mild to moderate dementia, which is who this intervention was designed for. And then we use a variety of cognitive assessment scores because when we were talking with the physicians indicated that they might use any number of different cognitive assessment scores. The MoCA, the Montreal Cognitive Assessment, has shown to be the most commonly used in the clinics where we're working. But there's also the SLUMS, which is the St. Louis University Memory Scan, I believe is what that stands for, and then the MMSE, which is very commonly used, just not as much amongst this population in the clinics where we're working. So we need to have certain scores indicative of this sort of mild to moderate dementia. We also need to have the patients who have an expected follow-up visit roughly 6 to 12 months later, because we want to get follow-up data on these cognitive assessment scores. And in this trial, we're only working with English-speaking individuals, despite the fact that the intervention is increasingly available in multiple languages. So that's the inclusion criteria. There's also some exclusion criteria. Of course, if someone doesn't have access to the online meeting platform, that's not something we're able to address here. If they have access but don't know how to use it, that we could help. We're willing to provide training and support for people to use an online meeting platform as long as they have access. We're just not able to provide the access. For individuals with severe auditory or visual impairment, combative behaviors, or other clinician-assessed conditions that would interfere with group treatment, they would be excluded as defined by the clinicians, by their physicians would make this determination. Some patients don't want to be engaged in research, and they've already told their clinics that they would not be included. That would be an exclusion. And anyone who's already participated in VCST and virtual cognitive stimulation therapy, we would not include. And then finally, this final exclusion criteria, I just want to speak to briefly. This is that if a physician determines that a caregiver is needed to support the individual with dementia to participate, but no caregiver is available to assist, then that would be an exclusion. And this, I want to just speak to this one briefly. We had to rephrase this quite a few times to get it right. There were earlier instances of this exclusion that would have excluded people with dementia who live alone, because many people with dementia who live alone, by definition, do not have someone who's living there with them to serve as a caregiver. And some earlier phrasing of this would have excluded anyone who was living alone with dementia, but research has shown people who live alone with dementia can successfully participate. So we wanted to make sure this was phrased in a way that kept that inclusion in. And so regarding this question of, VCST for people with dementia who live alone, so research has addressed whether this is possible, and it is indicating from the facilitator, sort of anecdotal evidence from facilitators of this treatment suggest that people with dementia who live alone could be coached to use Zoom and participate in the therapy. And I've heard that from facilitators myself, but I was glad to find this from a totally separate group. This is actually that same group in New Zealand who's continued to deliver this therapy. So in this trial, the sort of overall rundown of where we're at now is in both health systems, that primary care clinic and that neurology clinic, we scanned the electronic health records. They scanned their own electronic health records using our inclusion and exclusion criteria to identify a set of individuals who fit. And then they took that list of 224 people in the two separate clinics. The physician of the doctor of those patients is in the process of screening those patients to make sure, to exclude any who may have behaviors that they don't think would be appropriate for the group, or have conditions that they don't think would be appropriate for a group treatment. After that screening, then we randomize to intervention or control groups and give the list back to the physicians. The physicians then refer just the intervention group to virtual cognitive stimulation therapy. That is provided to them by a community-based organization. And then the patients will have a follow-up visit to the health system, and the health system is providing us the data. So again, we are not collecting any data directly from the participants. We are collecting data from their physicians, and specifically that data is their cognitive assessment scores. So before I end, I want to share two items with you, really meant to be practical. One is an opportunity to participate in cognitive stimulation therapy, and it is tends to be virtual, but I do think in person is possible. So Caring Kind is a community-based organization that I'm partnering with on my trial. It's been around for a while, since the late 70s, but it has changed name over time. And they are currently providing virtual cognitive stimulation therapy and in-person cognitive stimulation therapy. If you have an interest in learning more, I would encourage you to contact Caring Kind. Their phone number is listed here. And also they have this helpline email address, helpline@CK, that's caringkindnyc.org. So they are headquartered in New York City, but when they're delivering services virtually, they can deliver them to everyone everywhere. And they are providing the groups in English and in Spanish. Right now, I would note, as you can see here, that they have, it's noted as 16 sessions in 8 weeks. I would clarify, it is still those 14 core sessions, but they introduce sort of an orientation session so that caregivers and the participants could all learn more in an orientation session. Part of that was because a lot of the caregivers kept getting involved during those 14 sessions, and they're not supposed to. So by having that orientation session, it's an opportunity to set the expectations. And then that 16th, that final session, was because people were sort of sad when it would end. And so that 16th session is a sort of a celebration, an opportunity to learn about other services and programs, so that it's not just ending at that 14 sessions, but an opening to new opportunities. And then lastly, a research opportunity specifically for people with dementia who live alone, again, who very well could participate in cognitive stimulation therapy. And this is work from Dr. Laura Gerling. She's a collaborator of mine at Towson University, and she's seeking people with dementia who live alone or their caregivers to participate in an interview. There's no cost to participate, but eligible participants will be compensated for their time, and they can learn more about this opportunity from a website which it may not be the easiest to see at the bottom right of this slide, but it is agingresearchnavigators.com. And Dr. Gerling, I could assure you would be wonderful to participate in an interview with. So I just wanted to share this in case someone might be interested. But thank you very much for your time, and I welcome any questions.
Thank you so much. This is really exciting. And from the dementia-friendly perspective, you know, as we donate and invest in the cure in terms of the pharmaceutical end of things, what we're really trying to work on through the Dementia-Friendly initiative is these non-pharmaceutical, you know, practices and processes and research that can really enhance our quality of life, right? And to see that it's being used globally is really wonderful. So put your questions in the chat. We have time for a few now, and then again, following up, if there's any, we can continue with the questions at the end, but we have one from Ben Dubin. Is CST effective for Alzheimer's, Lewy body, and frontal temporal dementia?
Ben, that is a great question. I will just first acknowledge I cannot fully answer. I could answer partially that it has been identified as effective for Alzheimer's, but I cannot confidently answer for Lewy body or frontotemporal dementia. I think it's a really important question, and I'm sure we could answer it with some, skimming through the literature. I don't have it on the top of my head, so I'm not 100% sure, and I don't want to answer incorrectly. But I do want to say it's such an important question, so thank you for that, and it encourages me to go looking for the answer soon.
Thank you very much. Wonderful. Are there any other questions at this point that you want to put into the chat? Also, earlier, someone asked if the presentations and the recording will be made available, and yes, all presentations and the recording will be made available. Any other questions for now? You will have an opportunity to think about it, let this steep, and ask questions of Dr. Lepore after we hear also from Melinda Webster. So stay tuned. Michael, are you staying till the end in case there's
I'll stay till the end.
Okay.
Thank you very much.
Wonderful. Lovely. Thank you very much. Well, let's go ahead, and it's my honor to introduce, last but not least, our esteemed researcher, Melinda Webster. She's a research project manager at AgeWell Collaboratory at Drexel University's College of Nursing and Health Professions. She's presenting on behalf of and in collaboration with Dr. Laura Gitlin, who is the Dean Emerita and the Distinguished University Professor at Drexel University's College of Nursing and Health Professions. And she's also the co-principal investigator of the We Care Advisor study. So we're so delighted to have you with us, Melinda, and take it away.
Thank you so much, Emily, and I really appreciate this opportunity today, and just having listened to the other presenters, I think actually was the perfect spot for me to be able to discuss today. So you've heard a lot today about things such as depression and types of behaviors, which is a lot of what I'm actually going to be discussing today. And Dr. Lepore's presentation just about non-pharmacological interventions directly leads into really a lot of what the We Care Advisor study is about. So it was a perfect kind of lead up to it. So going into it, as Emily just mentioned, so I do want to acknowledge that the We Care Advisor study is a study that is an R01 funded by the National Institute on Aging.
Melinda, may I interrupt just for a moment? Sorry, forgive me. At least on my computer, and I just want to double check. We see your presentation slide, but we also see your notes.
See my presenter notes.
Yeah.
That is odd. Thank you.
May be helpful, but I don't know. Yeah.
No, that's very strange, actually. I thought I had tested it earlier, that it didn't.
Yeah, I didn't see those earlier, but I just wanted to pause. We have time to try to help with that if you want, and if not, we can simply go ahead with what you have. But
would you mind actually sharing on your end then? Actually, that would be
yeah. Let's see, Diane or Deja, do you have it?
It's not a virtual presentation or panel without some sort of virtual stuff.
Right. Okay, let me go ahead and see if I can find it. This is yours, correct?
Wonderful. Yes. Thank you so much.
Okay, hold on. Let me just get to the slideshow from the beginning. Okay, but for some reason, still now, even on my end, that is coming up.
So I do not see...
Emily, that looks fine.
Yeah.
It does. Okay. All right. So let's go ahead and just say next. Let me just practice next slide, or is it? Yeah.
Perfect.
Okay, great.
All right. Thank
Good.
you so much.
All right. Thank you. Thanks, Ethel.
All right. Yeah, we can go to that second slide. And I do just want to acknowledge that I am presenting on behalf of Dr. Laura Gitlin, who is with myself at Drexel University's College of Nursing and Health Professions. But also the co-principal investigator for this study is Dr. Helen Kales over at UC Davis. Okay, next slide. All right. So as a bit of background, as I mentioned, I'm going to be discussing a lot today about what we call behavioral and psychological symptoms of dementia. So you'll hear me use the acronym BPSD, behaviors, and so on very frequently today. And the big thing to note is that BPSD are a common part of dementia. They're often one of the chief challenges caregivers report that they face when providing care for someone living with dementia. And BPSD, they're including a variety of symptoms, but some common ones are things like aggression, agitation, wandering, hallucinations or delusions, but it also includes things like hygienic complications, so eating, appetite changes, behaviors related to bathing, toileting difficulties, and so on. And the big thing to note is, I know that there was someone who mentioned in chat earlier, what's the relationship to other types of dementias? And something to know about BPSD is that they occur in all types of dementia. So some might be more frequently in certain types of dementias, but they do occur in all types and at all times throughout the disease life course. It's also not uncommon for a caregiver to report that they're managing multiple types of behaviors at the same time. Next slide, please.
Okay, I'm just going to pause. I have in the chat someone saying they can only see the main slide. I'm just going to pause for a moment and check in with our technical support folks. Can everyone see the slide that says background on it?
Yes, that's what I see.
Okay, thank you. Okay, we'll go ahead now.
Wonderful, thank you. All right, so I do want to acknowledge that I included this slide just in case for their fellow researchers and who are attending today, just in case they wanted to see this. But I do want to just acknowledge this can look very overwhelming, but I will break it down to what I'm actually going to be discussing. So this slide shows a conceptual model that was developed by Dr. Gitlin as well as her colleagues, Dr. Kales and Dr. Lopetsos, and it proposes and expands upon an explanation for why behaviors occur in dementia. So what influences them and what can be done to treat them as well. So at its core, this model suggests that BPSD are caused by brain circuitry disruptions that are due to the disease along with its progression. And these disruptions can increase a person's vulnerability to certain types of what we call triggers. So we break it down into 3 types of triggers. So there's triggers that are related to the person with dementia directly. So pain, hunger, perhaps an undiagnosed infection such as a urinary tract infection. There's triggers that could be related to the caregiver. So caregiver depression, unrealistic expectations of care or disease progression for the person they're caring for, as well as even a negative communication style. So getting frustrated, maybe not knowing how to work through stress when something just isn't going right. And then there's final triggers that could be related to the environment. So that could be overstimulation, noise, maybe it's too hot or it's too cold and the person with dementia can't communicate that. They could be in pain. Pardon me, that's actually more related to the person directly, but also things like limited light exposure we see as sometimes being a trigger as well. So what this model encourages is really for clinicians to think of behaviors as complex. So they're multifaceted. And so you can assess for these different types of triggers because these are things that could potentially be modifiable. So optimally, this would be used to decrease the need for psychotropic medications or to delay them to really prioritize looking at non-pharmacological interventions or strategies first. And really the takeaway here is, again, these factors are modifiable. So if there is an effective treatment that could maybe look at different kinds of combinations of strategies to address a certain symptom, it could lower vulnerability in the person with dementia to reduce behaviors without needing to use medications. Next slide, please. So the big issue with that is a lot of the time families aren't included in that conversation. So they might know that these behaviors are occurring. They're seeing it in the day-to-day life. Maybe they're at a neurology appointment and the neurologist or their primary care physician is noting, oh, the person with dementia seems depressed, or maybe they're expressing agitation, but the families might not know that. Maybe that's only being written in a chart. So a big issue is that families need to be included in the conversation around behaviors so that they themselves can help identify these different modifiable areas. So a big part of that is just families don't receive education around behavioral and psychological symptoms like they would with other types of components of dementia, such as just cognitive decline in general. But because of that, families also just don't know why these behaviors are occurring or how to prevent or manage them. So for caregivers who are in the presentation or at the chat today, or maybe people who work with caregivers, it maybe isn't uncommon for someone to say, well, this is on purpose, it's intentional, oh, they're just doing it for attention, things like that. So for this reason, families may also not know when to call their doctor or healthcare professional. And without proper treatment, behaviors can lead to worse outcomes, not only for the person with dementia, but for the caregiver as well. So increased healthcare utilization, more rapid disease progression, and just overall poorer quality of life, both for the caregiver and the person with dementia. Specifically, the latest Alzheimer's Association Facts and Figures reports does suggest that caregivers who are managing more than 4 behaviors report higher rates of physical, emotional, and financial difficulties. So also higher rates of chronic conditions, so depression, anxiety, as well as cognitive problems. So we know that there's a big problem here, but how do we address it is really what we're trying to get to the core of. Next slide, please. So that is where things like non-pharmacological interventions can come into play. So right now, behavioral medications, so anti-anxiety medications, antidepressants, or other psychotropic medications are the primary kind of first line for treating behavioral and psychological symptoms. And while I do want to acknowledge they absolutely do serve a purpose and they can help, sometimes they can do more harm than good depending on the individual. And they often don't necessarily address the behaviors at their core that families might have sought out to seek treatment in the first place. So non-pharmacological interventions can be more effective than medications because they directly address the behavior that is of concern. So they are family directed. They really are looking at what is specifically the most important to the person with dementia and the caregiver. They're also low risk and non-intrusive because they're education-based or skill-based teaching strategies. They can increase caregiver confidence, but it is also important to remember these interventions are not one size fits all. So to successfully implement them, it's vital to tailor these approaches to each unique care situation. So one thing you'll hear me say a couple of times is one person with dementia is one person with dementia. One caregiver is one caregiver. One care situation is one care situation. Everyone has very unique needs and also different experiences, cultures, and values. Things like their professions, their hobbies, their race, all do factor into what is vital and actually important to them. So again, it's really vital that we do tailor these approaches. And I'll discuss that further on, but this is where the We Care Advisor comes in and how it was developed as a non-pharmacological intervention. And we really decided to use something that we call the DICE approach, which I will be breaking down later. So we can move to the next slide, please. All right, so moving into what is the We Care Advisor, and you can actually hop over to one more, I apologize. But what the We Care Advisor is a web-based tool. And what I mean by that is it's an application that's accessible on the internet, any internet capable device. So that could be a desktop, a laptop, a tablet, as well as a smartphone, because it's available either just as a browser, a link that you reach on a web page, or as a mobile app. So in the app, caregivers are able to access and manage the behaviors that they might be dealing with, so things like agitation, wandering, etc. And then the We Care Advisor provides tailored strategies to help caregivers with those behaviors. So it also includes areas for caregivers to learn more about dementia and caregiving as well. Ultimately, the goal is to provide caregivers with this resource so that we hope it can help them with managing not just the behaviors, but also their own distress by increasing their confidence in just caregiving overall, as well as with managing these behaviors. So before I delve into how the We Care Advisor works, I do just want to walk through how we actually developed it. So next slide, please. So the We Care Advisor initially began with a focus group that the investigators conducted. And with that, they managed to identify 3 key themes that caregivers would want out of this kind of tool. So first, it's that caregivers are willing to use a web-based tool, but they want it to be intuitive and easy to use. So it shouldn't require extensive training to understand how to use. The second is that caregivers want something that can be a one-stop shop for vetted information. So while there's a wealth of information available online, not every care situation is able to be reflected or that is benefited by that information. And so what caregivers might be finding might not be applicable to them, or they might question, is this actually trustworthy? Is this real? Is this something that I can really implement and know is not going to be hurtful, or is it even true? And then lastly, every care situation is unique again. And so one size fits all approaches don't work. So we wanted something that caregivers wanted something that could be tailored to their specific needs. We can move on to the next slide, please. So with those themes in mind, we began developing the We Care Advisor tool. And specifically, we looked at how we could create a platform that would be accessible online to both mobile and web-based devices. The reason for that being, caregivers are already very active online. They're using apps and mobile devices and just online internet searches to assist with their caregiving needs. So looking up symptoms, searching for resources, or keeping notes that they can share with their doctor. But it was very important to us that we do acknowledge that not every caregiver has access to a high-speed internet on, say, a computer, particularly those in rural or low-income areas. However, we did look at the research, and a majority of individuals do have internet access, at least through cellular data. So we did want to make certain it would also be available through a mobile device as well. But we did also want to keep in mind, aside from needing to be easy to use, We Care needed to be available on demand. So caregivers can access it at any time of day or night. So they're not beholden to trying to access a hotline or reaching an individual. And also that it can be repeated as many times as needed. Again, caregivers are often managing multiple types of behaviors at one time. So they need a tool that can address and keep up with all of those challenges. So here comes the We Care Advisor. If you don't mind going to the next slide, please. So I'm going to be really flying through these next few slides, but this is kind of the base of the We Care Advisor. So it contains a variety of resources to help caregivers address those behavioral and psychological symptoms and their unique caregiving circumstances. It includes vetted information, something we call a peer navigator, as well as those tailored strategies. So first things first, we're going to talk about the DICE approach. If we can go to the next slide, please. So DICE is an acronym that stands for Describe, Investigate, Create, and Evaluate. And it really serves as the bread and butter for the We Care Advisor. So for these next few slides, I'll be talking through each step and what that looks like in the tool. Next slide, please. So the first step of DICE is the D step, which is Describe. So at this stage, caregivers first begin by selecting the behavior they're managing out of 13 different options, ranging from aggression to hallucinations and so on. And when caregivers first click on a behavior, the tool does also provide examples of what that behavior might look like to confirm that that is what they are managing. And for the sake of the day, we'll be walking through these steps, looking at what a prescription for apathy might look like. So next step, please. Okay, so after selecting apathy, we're taken to the next page, which includes questions to describe how that behavior looks when it is occurring. So how its frequency, its severity, and if there is a risk to safety for both the person living with dementia and the caregiver. Next slide, please. Next, the caregiver is then asked to investigate, and they're prompted with very specific questions based on the behavior to weed out or identify possible causes for the behavior. So going all the way back to that theoretical framework at the beginning, we're really trying to pull out what are those potentially modifiable triggers with these questions. So overall, this process can take around 5 to 10 minutes, and it just walks through things like, have there been medication changes? Is the person in pain? And it does actually give an example for what pain might look like for someone who is not able to verbally express that as well. Next slide, please. And then that brings us to the See or Create slide, or step of the DICE prescription. So after caregivers walk through those questions from the tool, it develops what we call a prescription. And these are the tailored strategies that we are developing for caregivers to try. So several strategies are generated for the caregiver, and these strategies can, again, relate to the person living with dementia, the caregiver, the environment, and just overall health and safety, as well as potentially recommendations to maybe present something to a nurse or a doctor, depending on how certain questions were answered. And it ranges from general tips to things that are specific to the behavior that's occurring. When the caregivers first access the tool, it also asks information about kinds of hobbies that maybe the person with dementia enjoyed throughout their entire life. And also the strategy.
Hi, everyone. While we're waiting for Melinda to rejoin, we have a few announcements for some upcoming programs and current programs. So in October, we're asking you to save the date. Thursday, October 26th, we will have the annual Power of Age Expo. And there will be the Department of Aging represented, and the caregivers program as well as part of that, and Dementia-Friendly Baltimore County. So please join us in that expo, volunteer, sponsor, come as a participant, see what information and takeaways you can find. There'll be raffles and informative presentations as well. And on Friday, November 17th, we will have the annual caregivers program at the Atees Senior Center from 9 to 3. So stay tuned for that, but please save the date. For Dementia-Friendly Baltimore County, we are always seeking new members to join our leadership team. So this is a cross-sector, community-based initiative, part of Dementia-Friendly America. And we meet quarterly. The next meeting will be Monday, September 11th, 2 to 3. So you can reach out to me if you'd like to find out more about being part of this exciting public health initiative to raise awareness and education around dementia. And so you can reach me at Dementia-Friendly at baltimorecountymd.gov. Also, I want to say that we have ongoing memory cafes that through our mini grant program we're supporting. One is at Talmar Horticultural Center, which is near Cromwell Valley Park, and the other is at Pikesville. These are monthly events, so please reach out to us again at Dementia-Friendly at baltimorecountymd.gov, and I can send you those flyers and how to register. So I think that's it for announcements. We have ongoing caregiver resource sessions. We have support for respite waivers, so please reach out. I guess I'll give you the phone number to our caregiver program here. We are at 410-887-4724. So please join us for our programming, and if you need any support in your caregiving, or if you're an individual living with cognitive challenges and or dementia, please reach out to us. So thanks. We are still waiting for Melinda.
Oh, she's back.
Oh, wonderful.
Can you pull up her presentation where we were?
Yes, let me share again.
And I appreciate the patience. I've never had WebEx crash on me like that before.
No worries. We are here now. Can you see this, Melinda and everyone?
Yes, I can. Thank you so much.
And is this the slide that we were on? Slide 16, is this good? Okay, great. Go ahead.
Perfect. So I do apologize for that, and thank you for your patience in handling a little bit of virtual stuff. So the last thing I mentioned is just this create step for the prescriptions. And this is where caregivers can then see these prescriptions and strategies for them to try, and then to see if this is something that they can implement for themselves and the person they're caring for. So next slide, please. All right, and then the last step of the DICE prescription or approach is the evaluate step. So after a week, caregivers receive a prompt that it is time to see how are these tips and strategies working for them. And based on the response, the tool can then suggest new tips and strategies for them to use. So caregivers can repeat the DICE approach as many times as they like for multiple types of behaviors. But while DICE is the heart of the tool, it does include additional functionality such that we learned that caregivers want out of this kind of medium. So next slide, please. So the first are things such as daily tips. So these are sent by text or email and includes very general tips such as don't forget to breathe, as well as things that are more specific to the behaviors the caregivers are dealing with. And these tips are also stored on the WeCare tool, so caregivers can revisit them at any time. Next, please. There's also the Caregiver Survival Guide, and this is that one-stop shop for vetted information on dementia and caregiving. So if printed, it would expand all the way out to over 100 pages of information. And it ranges all the way from the bare basics of just what is dementia to what behaviors are, all the way to advice in identifying caregiving style and tips for certain caregiving problems outside of behaviors. Next slide, please. All right, and then lastly, this is what we call the peer navigator. So throughout those previous slides, you might have noticed that image of a woman on each of the comments on each page. So that is the peer navigator. When a caregiver first uses the tool, it asks them things such as their age, their gender, their race and ethnicity, as well as their care relationship. And because I'm a young white woman, the caregiver matched me with a peer navigator who is also a young white woman. The big thing to know here is that the peer navigator is featured throughout the tool, and it's meant to really serve as a familiar face and someone who has previously used the WeCare Advisor and how did they use it. It's also fully voice acted. So one thing that I just personally loved when we were first developing the tool is this particular page here. So these are all the peer navigators that someone can get throughout the study, depending on the questions that they answer. But despite your own peer navigator, you can read the stories of all individuals. And I just personally love seeing all the different care stories and how people use the WeCare tool. All right, next slide, please. So going into specifically the evidence for the WeCare Advisor, and you can also move to actually the next slide. I do want to discuss the pilot study. So while our current study is ongoing, I do have some data from our initial pilot, and this took place at the University of Michigan, Ann Arbor, as well as Johns Hopkins in Baltimore, and it included enrolled 57 caregivers from the span of 2016 to 2018. These caregivers were assigned to two groups, either an immediate access group who received access to the tool for 1 month right away, or a waitlist group who waited for 1 month after waiting for 1 month. So the study looked at how the tool was used, what caregivers thought of the tool, and whether it reduced caregiver burden and increased caregiver confidence. So next slide, please. So these are our participants. Again, it was 57 individuals. Baseline, there was no significant difference between the WeCare Advisor or immediate group and the waitlist group. On average, they were about 65 years old. They were mostly women. Most had a high school education and were spouses, and about 60% of them identified as white. Next slide, please. So the 1 month data was related to behaviors here. So we saw that agitation was the most common behavior at around 54.6%. And that was searched for and also had the most number of DEV sessions created for it. But also behaviors such as apathy and toileting did have more sessions than others with similar numbers of caregivers reporting them. Next slide, please. So very encouragingly, caregivers did largely find the WeCare Advisor tool to be helpful in that it did provide new ways to care for both the person living with dementia and for themselves. And very importantly to us, they found that the WeCare Advisor did not take too much time out of their day. Next slide, please. We also see that caregivers found the WeCare tool to be very easy to use, so it was not difficult, and it was very highly ranked in terms of the strategies, if it made care easier, and if they were satisfied, and if they would recommend it to other caregivers as well. So this is a pilot study, but it was a very encouraging set of first results for us to move forward with. And then the last slide for the pilot study, please. All right, and then here were some of the results that we were really looking for. So what this shows is that it illustrates the level of distress after 1 month of using the tool for both groups. So you can see that the baseline caregivers were about the same, but then over time, the 1 month group that was the immediate access immediately had a decrease in their distress. And this is distress in managing certain types of behaviors. The WeCare group, the waitlist group did have a slight decline, but you can see after they did receive access at that 1 month and then had access to the tool for a month, it did decrease from there. So this was a significant improvement. Okay, and then next slide, please. So this was the overall caregiver feedback, and I'm not going to read through each one, but we did see some just very encouraging, it's always good to receive this kind of feedback, even if it isn't hard data, particularly the fact that someone did identify that the person they were caring for had an undiagnosed UTI, and that's something that the tool triggered for them that they should talk with their primary care doctor about. All right, next slide, please. So I'm going to now just discuss our current study, and you can actually skip over one more. And this is the next phase iteration of that pilot study. So we took what we discovered from that and developed it further. So we are seeking 326 family caregivers, and this is national. We are based in Philadelphia, but we are including caregivers from all over. And the big thing to know here is that caregivers are initially screened for eligibility. They conduct an initial interview over the telephone, and then they're randomly assigned to one of two groups. So we're also looking at a waitlist control design again. So this means half of caregivers are going to receive immediate access to the tool and use it for the full 6 months of the study. The other group waits for 3 months and then gets to use the tool for 3 months. But it was very important to us that all caregivers do receive access to the We Care Advisor. Regardless of group, caregivers also complete follow-up interviews at 1, 3, and 6 months into the study. All right, next slide, please. In terms of our aims, we're interested in looking at a few different things for this study. So first off, does the We Care Advisor reduce caregiver distress? Does it reduce the frequency of severity of dementia-related behaviors? And does it increase confidence in managing the dementia-related symptoms for caregivers? We're also interested in, is there going to be a difference between benefits between the immediate access group and the waitlist group over 3 months? And then is there going to be a difference in the types of frequency reminders to use the We Care Advisor, and if that affects the use of the tool? So how often do caregivers decide to use it, and then their outcomes from that? Next slide, please. So who are we looking for? So what are our eligibility requirements? We're looking for, it says family caregivers. By family caregivers, we mean anyone who is not a professional caregiver. So this could be a spouse, a child, a cousin, a neighbor, a friend. So they just have to self-identify as the primary person providing care for someone with dementia. I will specify actually that I actually should have updated the slide. We did update our inclusion criterion that someone does not have to have a diagnosis of dementia. So this could be any etiology or type of progressive memory loss. So if they have a diagnosis, it could be Alzheimer's, frontotemporal, mixed, general, etc. But we are also including people with progressive supranuclear palsy, could be just a mild cognitive impairment, or as we see in many populations, maybe someone hasn't gone to a doctor to get a diagnosis, but we do test for progressive memory loss and can see if someone is eligible based off of that. They have to be living at home in the community, so not in long-term care. The caregiver has to be managing at least one behavioral symptom in the past 6 months, and then they have to have an email account or a smartphone. They're 21 years of age or older, speak English, and that they're able to use a smartphone, computer, or other internet-capable device. Next slide, please. All right, and so wrapping it up, if you are interested in the study, we are looking for caregivers. We have 3 ways that you can reach us. That could either be emailing our study email, which is wecare@drexel.edu. You can call our telephone line. You can also visit our study website, which is wecareadvisorstudy.com. And this on the website, you can fill out a form to request to be contacted by the study team. And scuff aside, that is the end of my slides. I do include some recruitment information at the end for people who are interested in seeing that. I'm happy to answer questions related to that, but otherwise it is just included in case anyone did want to see where we're at in our current study.
Do you want me to proceed with?
You can end the presentation unless people do want to see that recruitment
Okay.
information.
Okay, great. Well, thank you so much. And once again, it's really exciting to see you know, other ways we can support not only the individual living with dementia, but really importantly, the caregivers, the care partners, because we know it's impacting families, right, as systems. Let's check in the chat to see if we have any questions for you, but also for others. Let me go above the technical difficulties to look for questions, and you can put your questions in the chat, as I said before. I don't see any questions. But let's go back then. We have all three presenters here. So if you have a new question, but we had some left over that we didn't have a chance to get to. So let me go back to the questions earlier. Scrolling through the chat. Let's see. Good. Okay, let's see. These are for Dr. Garcia-Romeu. Okay, we asked, are these safe? Why not safe for folks with cardiovascular? Okay, so the next question is, are microdoses given outside of the clinic? Dr. Garcia, this is for you.
Hey, yeah, going back to the question of dosing, we use single high doses on 2 days during the treatment. We do not use microdoses. Microdoses have not been shown to produce any sort of benefit in anyone to date. The high dose treatments have shown antidepressant effects that last months afterwards. So that's what we're using as the higher doses. We use them on 2 separate days during an 8-week study treatment, and there's no microdosing or taking doses home or anything like that.
Great, thank you. A question from Scott Hill, also for you. I've looked at the contraindications for your study. I don't see any mention of medications participants might be taking, to lessen the symptoms of Alzheimer's. Have I missed anything, or are there no problems with those using such medications in your study?
There are certain medicines that would be exclusionary, things like monoamine oxidase inhibitors or MAOIs that could interact with psilocybin. But specifically, cholinesterase inhibitors like donepezil and other medications that are meant to enhance cognitive function, like memantine, for instance, would not cause any problems for interactions. And yeah, we can take people who are on those medicines.
Wonderful, thank you. A question from Linda Hutchinson-Troyer. Let's see. Sorry, just bumped up. Is this study available to persons outside of the Baltimore area?
If you're asking about my study specifically,
Yes, still. Sorry, thank you.
yeah, then they would have to show up for 6 separate visits over the course of 6 months, which would include screening, dosing visits, and then follow-up visits. But the rest of those visits are virtual. So if people are able to get here and back, we have had people from out of state, including Virginia and elsewhere, who have traveled to join the study.
Great. Still another for you left from earlier. This is from Ben Dubin. Have brain screens been done during your research?
We're not using brain scans in our study, but in the future, if we're finding good benefits, then we will use some MRI scanning probably, or EEG. Other studies have used EEG and MRI and have shown that there are changes in brain function associated with these drugs that seem to be associated with antidepressant benefit, things like changes in brainwave activity and theta activity, and changes in amygdala reactivity as well.
Great, thank you. From Allison Wood, again for you, could this eventually be tested with patients in later stages of AD, Alzheimer's disease?
I would not use a high dose treatment in folks who are in later stages, mainly because there's a possibility that could actually exacerbate some of the symptoms that they're going through at that stage. I think at early stage seems safer and more appropriate. It's possible using lower doses, maybe later on in the disease progression, but nobody's done it yet, so we don't really know for sure.
Great, thank you. Another one for you, an earlier question. Let's see, are participants paid?
Participants are not paid for joining the study, but if they need money to travel from out of state, we have some funding available for that.
Oh, interesting. Okay, great. I think that's all that I see in the chat. If I've missed anything, let me know. We still have a moment or two for any additional questions. Maybe the panelists, if you wanted to, oh, one more, yes. One more, go ahead and put it in the chat, please. Let's see, again from Jackie says, and I don't know who this is to, perhaps any of the group, do you know what the increase in persons living with dementia comes from? Any panelists could jump in here. So there's been, she's talking about the increase in living with dementia, I think.
So I'm probably the least qualified to talk about it, but a large reason why we're seeing the increase in numbers and the projected increase of numbers is because of the baby boomer generation. The number one risk factor for developing dementia is age. So as we're seeing this bubble of individuals reaching a greater age, we're anticipating that is going to be the reason why there's going to be an increase in number of people with dementia. There's, of course, other factors that come into play, so other health factors, but the reason why that number is projected the way it is because of that.
Thank you so much. Does anyone want to add to that? Any of the panelists? No, good. Well, I want to thank all three of you. It's just been a remarkable session, I think, and especially so substantive in terms of hope, you know, and again, that's what the caregiver program here in Dementia-Friendly Baltimore County is trying to message, but in a very substantive way. So we're not being Disney about it. We know there's challenges. We also know there's a huge, you know, fundraising effort. In the meantime, we really want to emphasize quality of life. You know, once we get a diagnosis, there's a lot of good living to be done is what, you know, our message is. And all three of you, your presentations provide tools, you know, and research that's really looking at that. Again, these presentations are going to be made available and the recording to participants. There'll be a short survey after. We're asking people for feedback about this session, but also what other types of programming would you like to see? Again, if you want to follow up with me about any of the programs that we have, please email dementiafriendly@baltimorecounty.md.gov. And again, thank you panelists and thank you participants for showing up for dementia and for doing such important work. Have a good rest of your day. Thank you.